Good afternoon. Well, thank you so much for inviting us here. I wanted to give you a little bit of an update on where we are with some of the insurance market reforms, the implementation of the exchanges, where things are post-Supreme Court with Medicaid expansion, and then to focus most of my time on some of the delivery system changes that we're making. As Glenn mentioned, that I was at the Innovation Center at CMS before this, so my background is mostly in payment delivery models and particularly worked on the Accountable Care Organization regulation rollout and the Pioneer ACO model that's out, and so thought I would talk a little bit about that. So first, just for a snapshot of where we are, the first thing that we did related to the Affordable Care Act implementation was really just around insurance market reforms and regulations. It was the so-called Patient's Bill of Rights, things like no lifetime caps and coverage originally for kids for pre-existing conditions. Adults will come online next year. Coverage for preventative benefits, the coverage of young adults unto the age of 26. Actually, 3 million young adults have taken advantage of being covered by their parents' plan, which is exciting. So already seeing really great effects of that for our young adults, particularly those in a tough economy who are taking advantage of that. So a lot of market changes around insurance, and I'm sure that either personally or your practice has been affected by that. Second, we're building our exchanges very rapidly. Obviously, this is an enormous endeavor for Health and Human Services and the consumer oversight operation at CMS. States have a limited time in which they could still tell us whether or not they're going to be running a state-based exchange or they're going to have us in the federal government step in and run a federal-based exchange. So far, we've had 13 states and the District of Columbia submit letters of intent to operate their own state exchanges. They have technically until November 16th to submit that letter of intent, so we imagine that after silly season ends next Tuesday that we might get some additional letters, but you should also be prepared. I bet there'll be a little more time allotted to that, though that's not official. There are plenty of states actively working to build their own exchanges as we are working to build the federal exchange and what that will look like. A big part of that, obviously, is understanding what coverage will be a part of those benefits and what are going to be the essential health benefits covered. We've put out some guidance just in the form of a bulletin, so this is not binding regulation at this point, so we don't have further guidance on it, but basically we asked folks to submit a plan, a benchmark plan of those 13 states that are planning to run their own exchanges, tell us what plans they plan to benchmark on for their essential health benefits, and that will greatly affect coverage for your services in particular. We have not yet really, many states have told us already which plans are going to benchmark. We haven't made that public yet, and you should be able to see more of that information in the next weeks to months. So that's sort of the update on the exchanges, again, moving rapidly forward, and I think you're going to see it even get much more busy around this development in the next year in terms of navigators and putting up the sites themselves and really figuring out how to make sure the coverage is appropriate. So that's another piece. And then I wanted to mention Medicaid expansion. So as part of the Affordable Care Act, there is an expansion of Medicaid to make sure we increase coverage to about 16 million new recipients, up to 133% of poverty, all folks who fall into that, not just those with children, so this will include childless adults. So this is it's a major expansion from many states. I was talking to the folks in New York earlier today, and obviously New York is a very generous state in terms of Medicaid, so that expansion won't affect states like New York, who are already very generous, but it will affect a large majority of states. Now, when the Supreme Court made their decision, not only did they uphold the constitutionality of the individual mandate, but they did essentially say that the Medicaid expansion was going to be an option for states. So now states have the option to say, yes, I'm going to expand, or no, I'm not. So I just wanted to give you a little more detail because I know you're doing a lot of work at the state level around Medicaid coverage for your own services. And so what I would hope you would do is also make expansion of that coverage a piece of what you're talking to your governor's offices about. I think we can all say that moving towards coverage is a good thing for patients. We've seen the data that know that expansion of coverage, and we know that generous states like New York who have expanded coverage not only have decreased mortality, improved quality, but they actually have decreased overall cost for that population. So we're paying for them one way or the other. We'd like them to have insurance, and we pay for them through the Medicaid program. But I'll leave that aside. What I want you to understand is that this expansion of Medicaid is 100% paid for by the federal government for the first 5 years. It does decrease from 100% to about 90% in the out years. Right now, if you know what the Medicaid breakdown is, federal versus state, it's more in the 50 to 70% range. So the fact that the federal government is paying 100% of the expansion costs is a very big deal for states. And I think once silly season ultimately ends, that governors will understand that that is a really big opportunity for their population to expand coverage. I think some of the concerns we did hear from governors was saying, hold on, this is a bait and switch. We're gonna say, all right, we're gonna expand coverage, you're gonna give us 100%, and a year from now, when whatever budget cuts come down the road, this is the first thing that's gonna go, and then we're gonna be stuck with all these people. But we've clarified for them that they can come in to Medicaid, and they can go out of that expansion at any point. So I think that flexibility and that ability to come into the Medicaid program or that expansion and go out will reassure governors that they're not going to be locked into anything, and they can see year to year where we're going to be. So I mentioned that in greater detail because, again, I know you're doing work at the state levels, and we do think that the expansion is a really critical piece of the Affordable Care Act in terms of taking the costs that are currently in the system. These are people who are already seeking care, but putting it into the Medicaid program so we can actually get folks to see primary care, see yourselves as well. So, and then the last thing I wanted to mention was the small business tax credits for those who provide health insurance. So I imagine most of you run small businesses, and I just wanted you to be aware of the small business tax credit that is available to help supplement some of your funding. You do have to pay at least 50% in terms of a matching rate for that to qualify, but I know a lot of people were already doing that for their employees, so I wanted to make sure you knew that was up and running as well. And then I'm changing gears from the insurance side to some of the delivery system changes. Wanted to talk about a couple of things. You know that you can sort of see the trend in where we're changing our payment methodology is that we're moving to a place of trying to pay for value. I don't think you can open the newspaper without seeing the fact that everyone's budget is tight. And we want to get more for our dollar, and we want them to go further. And you will start to see that in some of the payment methodologies. So a couple of things. So yesterday, we finalized our rule around the value-based modifier for physicians. And so that is, again, there are particular issues to podiatry that don't fit this, but I sort of bring it up to just highlight the trends and where we're going. But it's going to apply only to practices that are 100 physicians or more. And then we'll ask them to submit quality metrics, and then we will pay or take away some of those payments based on their quality outcomes. So a value-based modifier was finalized yesterday. For hospitals, we have the readmission reduction program. So we've clawed back some of the hospital payments, about 1% to 2% of those payments, and we're going to be looking at their 30-day readmissions and on particular metrics, and if they're around, to start with, heart failure, pneumonia, and I want to say post-MI. So maybe not all in your wheelhouse, but on those three conditions to start with, And so I think it'll be a new era of hospitals looking at their quality, looking at their discharges, looking at their readmissions, again, all to move us to a place of paying for more value. And the last thing I wanted to talk about, and then I'm happy to open to questions, is about accountable care organizations, and this is sort of where I had done most of my work in the last several years. As part of the Affordable Care Act, it established a program for a shared savings program. So where an entity comes together to be accountable for the total cost of care of a patient. They're Medicare fee-for-service patients in particular. And if at the end of the year we add up the total cost of that care and we see that it's lower than compared to a benchmark, then that ACO gets to share in some savings and the government gets to share in some of those savings. So I think this is, again, an exciting opportunity, particularly for podiatry. We were talking about this as a group last week. I think it's an opportunity for any provider that can show that they're providing care to their patients at a higher quality and lower cost. Now, patients are attributed to an ACO based on where they get their primary care. That's one thing to know. So their primary care providers are really the ones that create the ACO. A patient does not sign up for an ACO. This is not an HMO. They don't sign up for anything new. They are just a Medicare fee-for-service beneficiary, and that's what they are. They can still see any provider anywhere at any time. There is no lock-in, right? Again, they're not signing up for something. But what I think this is doing is creating a business context for those ACOs to look for who are the right care providers in the right settings to provide the most cost-effective care and high-quality care for these patients. So I think, again, it might take some proactive work from some of the different specialties, podiatry including, to say, let me show you the business case for our services. But I think it's going to be really important for you to be at the table and be participating in a lot of these models as we do an evaluation to understand where do patients get care, what types of services are they accessing at different points. So again, we're creating a new business context where it might have not existed before in a fee-for-service only environment, for folks to care about site of service and who's delivering that care and the most cost-effective setting for that care to be delivered. So we're doing that both in the Medicare Shared Savings Program, which again was established by the Affordable Care Act, and it's an ongoing program. We have about 154 accountable care organizations up and running, with another probably 70 to 80 that have applied to start in January. We also have a new model from the Innovation Center called a Pioneer Accountable Care Organization, where we not only do the shared savings that I was just talking about, where at the end of the year, if there's lower cost, the entity shares some and so does the government, but we're actually moving from fee-for-service to a partial capitation environment, which is a really very different place for major organizations to be in. So they're going to get a lump sum up front for particular patients, and they're going to have to decide how to allocate those resources. And again, a very critical opportunity, I think, for all medical specialties, including podiatry, to be at the table to say, this is where we fit into the care continuum, and this is where our value add is, and we should be part of, let's make make sure a contractual arrangement or financial arrangement is part of what an accountable care organization is thinking about, and particularly those pioneers. So I guess those are my comments just to start, and then I was just happy to answer any questions, and just wanted to thank folks again for the invitation, and I'll take it from there. Sure.
How does the ACOs, if it's patient choice and they see their primary care physician, and let's say they want to go to a podiatrist, and that podiatrist is not within that particular ACO, okay? But the patient has the right to go to that. How does that affect the overall monies that are going to that ACO, and how does that work together?
Sure. So the total cost of care to that patient is calculated regardless of where that patient gets their services. So it's obviously, for the ACO, it's in their best interest to try to understand where their patients are getting care, and try to provide them in the most cost-effective setting possible. Now, patients can, like I said, go anywhere, but I think what's important about the business case that we're creating is that I don't want to say this in the wrong way. What is it? Good pastures make good fences. When there's good care, the Accountable Care Organization, that's how they're going to make their money or make their shared savings. It's not by lock-in. And so you can imagine that two scenarios. One is that, say, a podiatrist is not part of the Accountable Care Organization and the patient just goes on continuing to seeing, but it means you have a personal relationship probably already with the patient and you're continuing care. But you can imagine a situation where you are actually have gone to the person who is leading the ACO and make some sort of contractual arrangement to say, we want to be part of this, whether it's the share in a percentage of the savings over the course of the year or some other sort of financial arrangement. Then it might be in the best interest of the primary care doctors or the way the system is designed to refer their patients to you for their services because they think it's going to be a lower cost setting that's going to be ultimately cost savings overall for that patient. I don't know if I made sense. So you could see different scenarios and how you can approach this, but I think it's going to be either way a new business context for the services that you provide.
Is it public information of what providers are in ACOs and who's applied for ACOs? And is Medicare beneficiaries, is it going to be public information that they even realize that they're part of an ACO as they're getting discouraged to go to maybe certain providers because the family doctor's like, yeah, oh, I can treat that?
Right. So all of the folks who are currently ACOs is public. Now, we do not necessarily make public which primary care providers are necessarily part of that, right? Because it's not really only limited to primary care providers, right? There's going to be a lot of other folks who are related to the ACO that Medicare doesn't necessarily need to track, right? So an ACO can have a financial relationship with its cardiologist practice, for example, and they are part of the ACO, but that's not, from Medicare standpoint, that doesn't matter to us because we are just focusing on how you attribute the patients, and you attribute based on primary care. So we didn't want to get into a messy situation where we're listing out doctors that are part of an ACO, but yet there may be more. So we've left it to their own accountable care organizations to decide what they're going to make public in terms of who's participating necessarily. And again, because there's no lock-in, most places are not doing that. So that's one. But then second, on the patient notification, this is a really, really critical issue about notifying patients of their rights to go anywhere and see any provider. And so there's a very meticulous process of patient notification in terms of notifying of their benefits. The only thing that they can, and we ask them if they want to opt out of data sharing as part of that process. So we hope that they would want to share data because that's, I think, we think that's the way that care is going to improve and care coordination is going to improve. But we understand people's privacy issues and such. So there is a multiple step process of notification over a period of time in addition to materials that we oversee to make sure that doctors are, and we're policing to make sure they don't steer patients in particular because we take that very seriously, as do all of the consumer advocates, as does the Department of Justice.
So if you're only really tracking the primary care and not who are the ancillary providers in that ACO, does that mean then the payment goes to the ACO corporation and
Yes.
then they decide how they may trickle
Yes.
that down to
Correct.
other providers in any equitable fashion that they feel is fit and you are not
Yes.
involved with that?
No. They need to submit a plan on how they plan to distribute the money, but it is not dictated by Medicare in any way and how that funding could get distributed. And frankly, the ACO doesn't need to distribute it at all. It could say we're going to keep it for infrastructure or the next, their next phase of EMR implementation or a next round of care coordinators, what have you. So we do not dictate that, which again goes to the point of where we wouldn't say a particular physician is part of an ACO in that way, because there can be a lot of different financial relationships as part of that.
Yes, it's a long question, but one question.
Okay.
What can you tell us about the dual eligibles? That's the Medicare public aid patients.
Yeah.
In the state of Illinois, they are trying to put them all into a big HMO type plan. Do you know anything about that?
Well, it's not an HMO plan, but I do know something about it. So there are demonstration projects in various states. Now, the state had to apply to be part of it. We have one going in Massachusetts and in Washington State right now. So what the plan is to put all of those duly eligible for Medicare and Medicaid into a way to better coordinate care for them and thus coordinate the payment streams for them, and put